Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. Find out about Lyme arthritis right now. My guest this evening is Dr. Paul DeMarco, a local rheumatologist and an authority on Lyme arthritis. Dr. DeMarco, welcome to Housecall.
Thanks for inviting me out, David. It's always a pleasure to be with you.
So briefly tell our viewers about your professional background.
So I am a rheumatologist, as you said, and I practice with Arthritis and Rheumatism Associates here in town. I have been in practice here in the DC area since about 2004. I was previously at Washington Hospital Center. My earlier career includes working at the Marshfield Clinic in Wisconsin relative to this discussion, and previously I was in the Navy from about 90 to 2001.
Very nice. Now, of course, the viewers are very interested to learn all about Lyme arthritis this evening.
Sure.
But before I focus on the topic at hand, all of our viewers are wondering, Paul, why do you have a fork on your lapel?
So that's a great question, and thank you for asking, because my professional society is using this fork to initiate a discussion we're having right now. This is the Simple Tasks program that the American College of Rheumatology is sponsoring, and the Simple Tasks program is to help viewers and other physicians and friends and colleagues learn that arthritis is a process that inhibits your activities of daily living, like eating. So people who have arthritis would have difficulty eating with any fork. I think you and I might have difficulty eating with this fork in general, but the message comes across about the problems of doing activities of daily living, and it initiates the discussion that we're having right now. So thank you for asking me about that.
Of course. So tell our viewers something about the background, the history, the discovery, if you will, of Lyme arthritis.
So this is a particularly interesting disease because it kind of has grown as I have been in practice, which in and of itself is interesting. It seems to have started around the time when you were starting in practice. A lady, a mother in a community, Old Lyme, Connecticut, had noticed that that particular street and those particular neighborhoods had more children diagnosed with then called juvenile chronic arthritis, than they should have, or juvenile rheumatoid arthritis, than they should have, and she called the Center for Disease Control and said, I have more children in my neighborhood with juvenile arthritis than I certainly would expect to see in such an unusual disease. Could you please come and look at this, because we don't understand that, and there are children involved. Sure. And the Center for Disease Control responded to that mother and sent a very bright, energetic young man, Dr. Alan Steele, who went up there and looked at this and said, my goodness, this is very unusual. So he started to look at these young people. He agreed that the incidence was unusual, but he also made a very, very important observation that there was a rash involved, sometimes, often enough, that it led to the arthritis, and that made him think that there was some type of infection. And that's where the research began.
The discovery, if you will, of this occurred in the 1970s, 80s.
Late 70s, early 80s.
Early 80s. So that's when it was discovered and first identified as Lyme arthritis.
Right.
But do you think this is truly a new disease, or rather it was first labeled at that time, identified at that time, but in retrospect it may have been around for decades, centuries?
So the clues that we have to answering that question would be that the agent of Lyme that we're going to talk about had been causing diseases similar to that in Europe, and the patterns of that disease are similar to what we have in the United States. The unusual surge of these symptoms in one place is what prompted people to identify it and therefore discover it. So it's probably not a new disease to the world per se, but it's certainly a new disease to medicine in the sense that the actual description of it occurred in the late 70s and was fully defined by the 80s.
So you mentioned how people contract this infection. You said it's an infectious disease.
Right.
Amplify that further about what exactly is the infectious agent and what is the means by which it's transmitted.
Sure. So the interesting component of this is that the agent of Lyme's, what we're really talking about, is a Borrelia or a spirochete, which is a surprisingly
A type
fragile
of bacteria.
That's right. It's a very fragile bacteria, which is going to be an important point later about it being fragile. But it is transmitted by what we call a vector. A vector is another organism that brings it to the individual. So what we've come to understand from Dr. Steer's studies and others is that the organism lives inside the tick, and over the tick's life cycle, from its nymph stage up to its adult stage, will go to different organisms, receive its meal, and in this case it's a blood meal. So as the ticks acquire their blood meal, they actually pick up the organism, the spirochete, the Borrelia, and harbor it in their salivary glands. And as they go from meal to meal, they pass the organism. So the organism actually lives in mice, and the organism lives in deer. And as the tick takes its meal from the deer and then moves on for its next meal into brush, which will be important later as we discuss this, then it will come and also look for a meal on a human. And when that tick bites the human, their glands will secrete saliva into the area of the bite. There's an exchange there, and there's actually a little bit of irritation from that, which will be important when we talk about the rash. But the critical issue is that the spirochete goes into the person, into their bloodstream, and that's when the process starts.
So to be clear, the tick acquires the infection from a deer.
So the tick acquires the bacteria.
Right, the bacteria.
From a deer, that's right. And we're pretty sure that this doesn't bother the ticks at all.
Does it bother the deer?
We think the deer may get some minor symptoms. Some people, this has been described in dogs, so
Yeah.
dogs can get symptoms from it, but humans seem to get the most symptoms from the spirochete.
Okay. So a tick has now this infection acquired from a deer, and then
That's right.
explain to our viewers how the tick gets to the human to release the infectious agent.
So the ticks are waiting for their next meal, and they wait in brush. And they wait in brush primarily because they've come off the level of the deer in probably a small hop, and they're going to kind of sit in that area. And when they're ready for their next meal and their next, in this case, quote unquote, host, which would be the unfortunate soul who acquires it, is close enough to the tick that the tick can jump onto them, then the tick will literally jump onto the individual and find a place on their skin and acquire their meal. That's right. That's how it works.
So a tick decides to jump on a innocent hiker going through the woods.
That's right.
And how easy is it for somebody to find a tick once it's on their body?
So that's a wonderful question. So Lyme happens in the summer and fall. When we're in the summer months, we're talking about being bit by a nymph, or the nymph stage of the tick, or the very early stage of the tick, or the young stage of the tick. And I brought my helper here from the U.S. Mint to show you that the nymph is going to be about the size of the inside of the D of the dime.
Very, very tiny.
So if you're looking for that small little black object, it's going to be hard. Later in the summer and in the early fall, when the ticks are adults, they're somewhat larger. They're closer to somewhere between a quarter and a half of an inch. And when they've had their blood meal, they'll be the largest, more towards that nearing a half-inch size. So very, very small. And you have to be particularly adept at finding them, and you have to be incredibly meticulous to locate them. But you can if you're good at it. But more to the point, the majority of people who contract Lyme disease do not remember the bite at all.
Mm-hmm. But if you find a tick, does it matter whether you yourself rip it off, so to speak, or should you go to somebody to take it off professionally?
That's a really, really good question. So remember, the organism is in the salivary glands of the tick, which is, think about the size we're talking about, and then the head is like really, really tiny. So it is possible to pull off the tick and leave the head behind, and you'll still get the transmission of the organism, which is a real problem. So there are some people who are very adept at covering the tick with Vaseline, which is what many doctors would do in their office, and the tick will literally sense the absence of the oxygen and back out, which is pretty amazing that happens. But pulling off the tick is hard, right? Because you may not do what you want to do. You actually have to get the tick to come out, and you probably want to get some kind of help if that's your concern to do that. And most offices can do that. You don't necessarily have to go to the emergency room, but offices in endemic areas, right, understand this point, and
Sure.
they'll take care of that pretty nicely for you.
So somebody goes for a hike on a Saturday of
Okay.
a holiday weekend, and they find a tick Saturday afternoon. Is it okay to wait until after the 3-day weekend is over to have the tick removed, or should they take?
Yeah, that's a good question.
Is sooner better?
Probably sooner is better, but really more to the point that the evolution of this infection happens after a period of time. The period of time is about 72 hours, and there have been studies very nicely done that have demonstrated that if someone has a suspicious tick bite and within 72 hours can get to a doctor and have a single dose of doxycycline 200 milligrams,
An antibiotic.
that will actually treat the process of the infection. So, there's a certain amount of urgency to it, perhaps. I think that experienced hikers would tell you they'd rather stay hiking than to run to an urgent care when they've been concerned. But there's certainly a window of opportunity where someone can safely intervene and be comfortable that they've still attended to their health correctly.
Now, we have 1 minute before we go to the break.
Okay.
Briefly tell our viewers how you diagnose Lyme disease.
Okay, so not so brief,
Okay.
but 2 good ways to do it. First is to identify the rash.
Okay.
So the rash is a bullseye spreading rash, usually has a central clearing, usually gets progressively further away from its center as it grows, can actually get surprisingly large, upwards of 20 centimeters in its diameter. That's pretty big. When the rash is present and the rash is diagnostic, that's all that's necessary. In fact, other testing isn't helpful.
We're going to pause right there.
Sure.
We're going to pause briefly for a public service announcement. When we return, more with Dr. Paul DeMarco and a fascinating discussion about Lyme arthritis. We'll be right back. We're back. My guest is Dr. Paul DeMarco, and tonight's topic is Lyme arthritis. Dr. DeMarco, when we paused for the break, we were discussing diagnosis of Lyme arthritis.
That's right.
And it basically breaks down to 2 components. One is clinical, which you were touching upon, and the other is laboratory.
That's right.
So let's go back to clinical. Are there any other presentations that would help make the diagnosis besides arthritis
Absolutely.
and the skin rash?
So this disease is really interesting in the sense that the infection occurs in stages. So the organism enters. You sometimes can get a little bit of irritation at the bite site. That's not the rash. The rash comes on about 3 or more days later at the site of a bite, and it's this rash we were talking about, erythema migraines. And the rash spreads at a single site. That rash will go away. No matter what you do, that rash will go away. And the confusing part is that going away of the rash is just the beginning.
Right.
The organism goes into hiding and will come back out. So there's a recrudescence. And the next event is what we call early disseminated disease. Now, there's 2 interesting things about this. One is that the spirochete is coming out and it's going through your blood, and you can get multiple erythema rashes.
Gee.
And that multiple rash expression is an expression not of a million tick bites, but of the tick, the organism from the tick being through your entire blood system. We call that a spirochetemia, a big long SAT word.
Yeah, yeah.
Might be a New York Times puzzle word, right,
Yeah,
for
yeah.
all we know. With that, you tend to see 2 other major manifestations and then a bunch of minor symptoms. So the minor symptoms are things that people think about when you have a cold. You can have a fever, you can have muscle aches, you can have joint aches without the arthritis, because we'll get to that.
Okay.
You can have a stiff neck. You can feel very tired. You can lose your appetite. Very nonspecific. But what is interesting about that is it doesn't affect your stomach and it doesn't affect your lungs. Right? So those are things we think about with the flu or influenza.
Right, yeah.
But influenza should have respiratory symptoms or GI symptoms, so it's different. The other things that happen during that stage are involvement of the heart and involvement of the nervous system. Now, there is a link between the 2 because the part of the heart that's involved is actually the nerves within the heart, the conduction system. So the most common manifestation of that would be heart block or varying components of heart block. Heart block is an event that a cardiologist or someone with an electrocardiogram would diagnose electrically. People sometimes don't feel a whole lot with that. They could be tired. They could find that they're having trouble responding to exercise. So very subtle, and you wouldn't pick it up unless you did the electrocardiogram or EKG or ECG. The other parts are neurologic, and the most interesting one of those, and the biggest clue in those, are cranial nerve palsies. That's a big, long word for the nerves that treat and manage activity in the face no longer doing their job. And of them, the most common of which would be a Bell's palsy, or an involvement of the facial nerve. So people would have a droop, they have trouble moving their eye. To some, it would look like a stroke, but it's only involving that one area. Unique to Lyme is the fact that you can get both facial nerves involved. So you can get a bilateral Bell's palsy. That is very odd, right?
Yes.
We almost never see that. In fact, this is only one of the only events in the textbooks that causes a bilateral Bell's palsy.
How interesting.
Some minor things, others can happen, but again, kind of related to the nervous system, because you can get it in the eye, which is very interesting. From my perspective, I have a little bit of interest in the muscle around the heart, because I do muscles, bones, joints, and related symptoms. And the muscle can be involved too, and you can develop what's called a cardiomyopathy. More common in Europe than in the United States, but still associated with borreliosis.
And
then that goes away.
And cardiomyopathy, to explain to our viewers, would be that the heart is not pumping efficiently.
The heart loses its ability to effectively contract,
Right.
and therefore would not move blood through the body.
And that would present with fluid overload in the lungs, or your arms, legs, edema.
Could be as profound as what we call congestive heart failure, with the inability to move the fluid out and get swelling in the limbs, to something more subtle, like the difficulty in performing activities or exercise, or ascending and descending steps.
Right.
We call it dyspnea on exertion, or shortness of breath when you're trying to do something. Most common manifestations of that. But again, that'll go away. very important to pick it up when that is happening, because that's when the organism is out. That's when the organism's in the blood, and that's the period that we want to treat. So the very astute clinician will see that and make that diagnosis, and that goes away. Then it can come back again and cause the arthritis. So that's the swelling of the joints. It's usually what we call in rheumatology a pauci-articular disease, which is a big, long, fancy word for less than 4 joints. Very classically larger or medium-sized joints, so knees and elbows, very common, not so much so in the fingers. And there can also get a inflammation of muscle, interestingly enough, around those joints. There is a myositis associated with this, which is interesting to me, right, because that's what I do. During the early localized phase, blood tests are not helpful. It's the second and the third phase that the blood tests become helpful. So we did talk about 2 things. One is clinical, and then the other is the special blood test.
Let me circle back to that comment. Why is it during stage 1 the blood tests are not helpful?
That's a great question. So the blood tests are specific to the immune system's understanding of the presence of the organism. And when the organism first shows up during the bite, the immune system is still trying to figure out what it is. So it doesn't have an immune array. And it's during the creation of the erythema migraines,
The skin rash.
that the skin rash, thank you, it's during that first skin rash, not the second one, but the first skin rash, that the body's figuring out what it has to fight. By the time the second manifestation shows up, the body has a sense of what it's doing. And the body creates its immune response in 2 phases. One is the generalized acute response, which is with IgM, and then the second is the more long-term memory ability for the body to see and recognize again, and that's the IgG response. Doctors draw blood tests that look at the immunologic response very broadly, and then draw a blood test that look at it very specifically, and that's called a Western blot, which my son does at his PhD program. So Western blots look at the specific immunoglobulins in how they map to this organism. And there's 3 of them in the IgM phase that are very, very specific. And then there are 10 of them that are specific in the IgG phase. So doctors look for the IgM phase first, and then the IgG phase later. Usually the IgM phase goes away, and the IgG phase comes up. So we look for 2 of the 3 of the IgM, and we look at 5 of the 10 of the IgG.
But am I correct in understanding that on the one hand, you as a clinician want to diagnose the, Lyme disease early to nip it in the bud, if you will, with early antibiotic therapy.
That's right.
And yet, the testing may not be positive when you make the diagnosis.
Well, that's true. I mean, the skin, that early phase, the
Yeah.
early localized phase, there are no successful blood tests for that.
Even
So
Western blot, it's not.
Western blot does not pick it up.
No. So you have
And we
to.
don't culture this organism.
Right. So you need to be prepared to explain to the patient you have a clinical suspicion, but you haven't confirmed it. But there's a
right.
rationale for early treatment anyway,
That's right.
which is pretty benign.
That's a cute pun. There's a rash
Yes.
and L.
Yes,
A
there we go.
rationale. That was good.
Okay, there we
So,
go. All right. Well, you went on to discuss phase 1 and
Right.
phase 2.
right.
Is there a phase 3?
So the third phase is the arthritis phase.
Okay. Okay.
And so the arthritis phase is the pauci-articular disease. You can actually have a recrudescence of neurologic disease during that period of time. There is a kind of a global difficulty in thinking. We call that an encephalopathy. You can get long nerve involvement. We call that a radiculopathy during that phase. But the most prominent part of it is the arthritis. And the arthritis is swelling and tenderness and limitation in a joint. And rheumatologists will take a sample of that fluid and look for presence of inflammation and correlate that with the blood tests to see if the inflammation in the joint corresponds to the array in the blood that would raise the specter of Lyme.
So you certainly made the case that early diagnosis and early treatment is appropriate. Let's first look at the patient that you've made an early diagnosis.
Right.
And the blood tests have not even turned positive.
That's right.
What kind of treatment is the patient looking at?
So there are two groups. So there's patients over 8 and patients under 8.
Okay.
Okay, so that's the first very important split off. And the reason why is because the best medicine for this, of all the things available to us, ironically, is one of the older medicines we have, which is doxycycline.
A type of tetracycline.
A type of tetracycline, and it's a twice-a-day medicine, usually given for several weeks, depending on what stage we're looking at. Children under 8 will get damage to their developing teeth, and so doxycycline in general is not given to them. Now, you remember in the first half of the show, we talked about the fact this is a fragile organism. Yeah. So it responds to amoxicillin, which is another older antibiotic. And
a type of penicillin.
A type of penicillin.
Right.
And this particular penicillin doesn't treat much. We use it for strep throat pretty commonly, but we tend to pair it up with other drugs when we're treating very complicated infections. This particular infection does very nicely in the under 8 crowd. And there are some people who can't take doxycycline, and we'll put them on amoxicillin, so the over 8-year-old crowd. We'll take it as a second-line agent.
Now let's go on to the other patient, the one who's caught much later in their clinical course. The test to turn positive. Right. And then in retrospect, everyone goes, of course the patient had Lyme disease. Right. Maybe erroneously carried as rheumatoid arthritis or something else. So how do you treat them? So
that's going to be treated by what manifestations that they have. So interestingly, the arthritis can largely be treated with oral therapy.
Okay. How long?
Usually it's at least a month, sometimes longer. Some people will take a second course, usually not more than 2 months for the arthritis. The heart involvement and the neurologic involvement usually are treated initially with intravenous antibiotics, so antibiotics that go into your vein directly, not the ones that you would take as a pill at home. And those are also done for several weeks. The world has changed since we started this, as you well know, and we used to keep these people in the hospital for this, right? Nowadays, with the technology that allows them to be outpatients, they will not uncommonly take intravenous antibiotics at home, which is really interesting. So some of my when I was in Wisconsin, some of my youngsters would go to school. They get their antibiotics, they go to school, and they come home and they'd finish it up. It was really fascinating.
Paul, this has been a fascinating interview, but much to my regret, we're out of time.
Okay.
If our viewers have any questions about Lyme disease, how can they reach you?
Well, you can certainly go to Arthritis and Rheumatism Associates website at Washington Arthritis or Washington Bone. You can contact us with the information that's provided on the screen for the office. All of the rheumatologists in my practice are very well versed in Lyme and be able to assist people who are having problems or concerns.
Thanks for joining us on Housecall.
Thank you very much, David.
My thanks to Dr. DeMarco for a very informative interview about Lyme arthritis. My thanks to my terrific team here at the studio, and most important, thanks to you, the viewer, for welcoming us into your home. Tell us how we're doing. You can reach me at my practice website, montgomerygastro.com. As for my next guest, it will be the president of the Montgomery County Medical Society. We'll be discussing public health issues in Montgomery County and throughout the state of Maryland. It's going to be a fascinating show. See you then next time for another edition of Housecall. Good evening.